So I hope with today's conversation, people will get a sense of what palliative care is, and they will get help for their loved ones when they need it. Thank you.
Absolutely. All right. So, just a quick, recap of what we are going to do in this session. So, there are going to be a lot of questions, and Dr. Priyadarshini will answer those questions, and we can keep the last 10 minutes for questions and answers from the audience. All right. Okay. So, let's begin. So, Doctor, before would you first like to share the screen and then I start? Yeah. All right. So, Doctor, before we talk about palliative care, I would love to begin with your book. So, Touching Hearts Gently is such a beautiful and evocative topic or title. So, what inspired you to write this book? And what experiences from your journey in palliative care can made you feel these stories needed to be shared?
Right. Uh, so again, bless you. I'm not a writer at all. Never ventured into writing. But during COVID times, I was looking after one of my friend's parents. Both of them, they had cancer. My friend was in US and his other siblings were also away. So I was practically a friend, a doctor, a caregiver, and a guide for the patients as well as their children. So, and it was happening for quite some time. And we all can imagine during COVID times, everyone was just feeling very lonely and disconnected from rest of the world. Elderly people for sure. So when my interactions with auntie and uncle, it was observed by my friend who's far away. He said many people need to know about what all you are trying to do, and it is a need for many others. So you start writing, and I was scared. I have studied in Marathi medium, and I wasn't really a good writer anytime. So he said, don't think about writing a book or anything. You just keep writing. Whatever you remember from your experiences, you keep writing and let me do the editing. Let me see how we can use it, where we can use it. Should we have a blog or something like that? Because he had some experience of writing the books, not in medical line, but he is an engineer. So he has written some texts related to IT, I guess. So then I had time, and I always remember my patients and their family members. I'm still in touch with many family members of the patients who have touched my life, and I have learned something from them. So it wasn't difficult. So I kept on writing whatever came to my mind of these patients, and that case, if we have to say, though we never say as a case because we talk about the person with the disease, right? So inspiration was time and initiation by my friend. As I started writing, I also felt that I have not done this exercise before. Doing this exercise of just putting down my thoughts, my emotions, as a doctor, as a person involved in their caregiving, and how it has impacted me in turn. That was very interesting because beyond our professional roles, we are human beings. And life touches us also by learning from what happens between patient and families, what happens between families, how they request to the doctors, and how doctors respond to that. uh, Between doctors, as a person, everybody is different, and that drives the way they care for patients. Everybody is well meaning, and it was very interesting exercise. So we could complete these stories. There are 29 stories. Each story is real, but I have changed the patient's names and diagnosis so as to, keep it anonymous. And I think every story will tell you the aspect of palliative care, how it can help. For example, many cancer patients towards the end, they stop eating or they eat less and less. And family members often have this thing like, how can I make him or her eat more? So, whether it is needed, whether it is necessary, how it can be initiated, should be initiated or not. All those questions, if you read such story, you will get some hint if you had to take some decisions, difficult decisions, I would say. So we did that in COVID times, and eventually Rajhans Prakashan translated it into Marathi. Uh, in this year, last year, they came out with a book called Sobat Sanzvelchi. It's edited by Padmaja Mehendale. It's also very well received in Marathi community. So, yeah.
Right, right. That is so amusing. So, listening to your journey, it's easy to see why palliative care is about so much more than medicine. So, for those who have joined us today, who may be hearing this word for the first time, how would you explain palliative care in simple words?
Yeah. So it's a very, very difficult task to explain it to somebody what we actually do. So, few basic things: palliative care or palliative medicine. It's a branch of medicine, just like we have other branches like medicine, surgery, gynecology. Today, that is since 2012, in India, palliative medicine has become a specialty. So, what does this specialty doctor do? It's not one person's job, and it will come again, but it's a teamwork. So, the doctor's role in the cases which are beyond cure or their disease is irreversible. Many a times you must have seen elderly people with dementia, which is progressive, Alzheimer's disease. Some patients, they have renal failure and they require frequent dialysis to survive. Such patients are probably going to live longer with their medical problems. But there is probably no complete cure. Like, you go in for some surgery, let's say appendicitis, your appendix is removed and you are back to normal. So, in palliative care patient population, that doesn't happen often. Our patients are sometimes going through the curative treatments. Like, for example, in cancer care, they may be taking chemotherapy, radiation, or they may have surgery. But along with that, palliative medicine has a role. How it is, I'll tell you later. So, in simple terms, if you have seen a child who is in the house, everybody is taking care of him, but he is put on somewhere and he is with one quilt. He is looked after so that he doesn't feel cold, but maybe he has taken it out and he is shivering, despite everybody trying to do everything. And a mother comes and puts in another layer of quilt, and he is comfortable with all his things. So this is that additional layer of care, I would say, where people, patients, and their family members feel comfortable to go on with difficult journey with help of palliative care team. That's how I would put it.
Absolutely true. Uh, so, since you mentioned about the child and some non-curable illnesses, but many people assume that palliative care is only for someone who's for someone in the last few days or weeks of life. Is that the biggest myth? And when is the right time for a person or family to consider palliative care?
Right. So, very important question. And I think we all must be very clear about when to think about palliative care. Many years back, when I was studying in Singapore, I saw that one person was diagnosed with cancer. And to reveal the diagnosis, they had called this patient, they had naturally asked, do you want anyone with you? Which is against, I mean, it is not a common practice here back then to reveal the diagnosis to the patient directly. Here, our family comes into picture. So,
Right.
when they were revealing the diagnosis, there was a radiation oncologist, medical oncologist, surgical oncologist, and a palliative care consultant. All of them, they sitting together, revealing the diagnosis and telling them that hence in your journey, everybody has a role to play. You can take anybody's appointment, and how palliative care person can help even when you are taking chemotherapy.
इंदिरा रामचंद्र पेशिया
Hello?
Yes, yes, ma'am. Go ahead. Go ahead.
Yeah. So, just to describe, you look at this figure. The earlier thought was palliative care is when somebody is dying. Here, somebody is diagnosed with, let's say, a disease like cancer, and their journey is going on. Disease is progressing, they are taking treatment, but despite doing all the efforts, there is no success and they are dying. Then palliative care used to come in picture, right? This is traditional model, and why it was there is a story behind it. Dame Cicely Saunders, who's a originator of modern palliative care movement in UK, during World War II, she was a nurse before. She noticed that those soldiers who were given extra attention more than their medical management would see better recovery. So it was not just medicines helping them get better, but something more to that. Some extra layer of caring was helping certain soldiers recover better. She spoke to doctors, nobody listened to her. Then she became doctor and she started first hospice in UK called St. Christopher's Hospice. But that time it was like curative treatment and then palliative care. Over the period, there are developments in the specialty, and this is the new model. Here you can see, here somebody is diagnosed with cancer, let's say stage 2 cancer. They are taking this treatment, curative treatment. Along with that, for example, a person is diagnosed with breast cancer, stage 2 breast cancer, which is with aggressive treatment completely curable today. But there are going to be side effects from the treatment. They are going to be feeling low for some time. They can't take their diagnosis thinking that why it has to happen to me only. And all such questions and answers, somebody in addition to oncologists need to be answering. Somebody needs to be with them. So the medical social worker who's trained in palliative medicine or a counselor can fill in that little part to make them ready to take more medicines or medical treatment. So it is not just for end of life or towards the end. It has a role during the treatment as well when you are taking aggressive treatment. Here in same picture you can see as the disease progresses, the contribution by curative treatment becomes less and less. But if patient is not doing okay or they are at home and they are surviving with some problems every day here and there, again palliative care has a role to play. When they are really dying, palliative care team, which includes doctors, nurses, medical social workers, counselors, nutritionists, physiotherapists, and even a trained family caregiver, They all have a role to play because it is not no more a one person's disease. It goes to everybody in the family. With the chronicity, everybody is involved. And when patient passes away, again, the family member needs support in terms of bereavement care. So again, our team is trained to support families, though those who are not, able to cope up with the loss of their loved ones. So the scope of palliative care is vast today. It is not just limited to end of life care, though end of life care is a very much part of palliative care.
Absolutely. And so, since I belong to Aaji Care, and many of the inquiries that we receive at Aaji Care involve families caring for a loved one with a life-limiting illness like dementia also. However, initially we spoke only about cancer. So, one important question is that is palliative care only limited to cancer, or is it also for people with conditions like dementia, Parkinson's disease?
Yeah, so we spoke about cancer and the reason for that. Palliative care, when it had started as a specialty, for larger point of time, it was given only for cancer care. It was later that people realized that principles of palliative care can be applied to different areas like pediatric palliative care, geriatric palliative care for kidney diseases, for chronic heart diseases, where surgery is not possible. Their heart is pumping maybe for 10 to 15% of ejection fraction, but they are surviving. Then how to look after them? So today, palliative care is not just limited to cancer care, but it has subspecialized into all these areas.
Okay.
So you mentioned about people when they come to Aaji Care, they want to know what more we can do to look after their patients. And that's the essence of palliative care. I spoke about what is the definition or what is palliative care. It is an approach, but goal of palliative care, why do we do that? Because it is an additional layer of care.
Okay.
And why this additional layer of care is required is to have patient and family comfort in looking after or going through this journey. Patient's dignity has to be mentioned. You by now would understand that nothing in this area is going to be very rosy picture
Hmm.
most of the times. And when they are going through these difficult times, they need to be comforted. They need to be looked after in a way. They need to be respected for what their wishes are. So they need to be understood as a person with certain things in mind. They need to be listened to. If they are not right, somebody needs to be sitting with them, telling them the pluses and minuses. Some patients say, we don't want to take treatment, curative treatment. So we need to tell them what is the benefit of taking treatment. If they don't take treatment, what happens?
Right.
It is when they have to decide ki enough is enough and just let them be as comfortable of as possible. And in whatever stage they are, whichever disease, whatever stage, they need to have a better quality of life. For example, yesterday only I met with a senior lady who was looked after at home fairly well. She was looked after fairly well, but slowly, because of the age, she was more and more bedbound. There was nothing major as a reason. She was in her 90s and she stopped getting up, going for to the dining table for dinner or whatever, and she was bedbound. Slowly, she stopped using her muscles, and now, when she came to me, she was almost having contractures of her hands and legs. She also had bed sore because there was no muscle mass remaining. She was eating less. So, when these problems start, we don't realize what is to be done. As a family, we generally try and feed them again and again. If they say no, there is a irritation between the patient and family. Sometimes we go to doctors, we get some protein powders, or somebody would say, uh, I have to put saline 2 times in a week or whatever. But the fact that because of the elderly population, elderly aging process, she is bedbound, she is not hungry all the time. So we need to make that distinction. Doctors are needed to assess that and tell you whether we need to give. If they are dehydrated, we need to give saline. But if not, then should we give, should we not give? All those decisions we have to make. So I have just put this picture for us to understand. Right? Again, in terms of chronic disease, you can see where I have put things like transitions. So, any change in patient's condition, in their disease journey, in their life limiting illness, any change, we need to be reminding ourselves that, okay, we are going to this doctor is suggesting this treatment. Along with that, whether palliative care would have anything more to add. For example, I can tell you in dementia population, many a times with advanced dementia, patients are probably not going to tell you that they are in pain. Unless they tell you, many of us won't understand that they are in pain. But there is definitely a way to look at patient's face while doing some activities, while shifting them, lifting them. And from facial expressions, we can easily understand that it is not very comfortable to them. Then should we be giving some medicine to make their movement comfortable is a part we have to understand first. So first we have to understand the disease, then we have to understand the extent of the disease, and then how we can make them comfortable in their current situation. So all these times, I think it's no harm just turning to palliative care person and asking, is there anything you can add?
Yes, absolutely. Just a small request, ma'am. I've received a request from a couple of people if we can mix Hindi, Marathi, English, because certain words are difficult for people to understand.
Sure.
Yeah.
Marathi is also okay?
Yeah. Hindi, Marathi, English, mix of everything.
Okay. My Hindi is not so great, but I'll try.
Sure. Okay, so I think we have understood the basics of palliative care till now. Just to lighten up the mood, I was just thinking whether we can do a quick myth busting round so that certain misconceptions around palliative care are cleared.
Sure.
So there are just 4 statements. I will read those out to you, and you tell us if that's a myth or a fact, right? So the first is palliative care means stopping treatment.
So I just explained it is not. It is just the approach of care is different.
Right. Accepting palliative care means giving up.
No, accepting palliative care, which means after knowing the details where your disease stands, choosing what you want.
Right. The third one is morphine should only be used in the last few days of life.
No, morphine should be used for any chronic disease patient who is in pain after complete assessment and proper calculation. See, the problem is morphine is blamed to be addictive for people who are not in pain. We take other pain medications as doctor prescribes. Morphine, earlier years when it was coming to India and it was a trade, there were stricter rules for using morphine, and therefore even doctors that time were not very comfortable prescribing morphine. But over the years, there are amendments, and now using morphine is like using any other pain medicine like tramadol They belong to similar group opioids, and it is wonder drug when it comes to pain management. It is just that it needs to be given under proper supervision by a trained doctor, stored properly, and reported if there are any problems, reported back properly.
Okay. All right. So now we have spoken about palliative care and who is it for, and we have also addressed some common myths. I think it would really help our audience to hear what palliative care looks like in real life. So you have written book and you have worked extensively with so many patients and families, and made meaningful difference to their lives. So could you share a story about a patient or a family where palliative care was used and it made a meaningful difference in their lives?
Sure. Yeah, I would share a story of a young girl who was very close to me, and we had a special connect, I would say. Uh, I have taken permission from her parents to put her photographs, but I would suggest not to use it for public forums. Uh,
Absolutely.
for understanding, I have put the photos here for you to understand the concept and how it helps. Another thing before coming to story, I would like to say that, many years back when newspaper reporter had asked me that how do you measure your success in palliative care. There are nowadays scales which measure certain things, but because palliative care it's so subjective, I think there are no scales which is like, you can say that I'm 70% happy or satisfied by whatever we contribute. And I think the reason that happens because every patient is different, every disease is different, and every doctor is different.
Yes.
So when we are talking about these stories, I may talk about one or two, but when we are talking about these stories, the ultimate goal of what we want to achieve through that is to make them comfortable, is to make them have some moments where they can smile again, they can be pain free, and they can still see a glimpse of better life. Yeah. So, this was my little friend. Once we got a call saying that this is the young girl who had bone cancer and she was suffering in real pain. uh, she came eventually to get admitted with us. She had a very bad pain, and I would like to tell her story in detail for everybody to understand. जेव्हा ती आमच्या वॉर्डमध्ये आली तेव्हा तो लहान मुलांचा वॉर्ड नव्हता. त्यात मोठे छोटे सगळ्या प्रकारचे पेशंट होते. बायकांचा वॉर्ड होता आणि त्यातल्याच एका बेडवर तिला घेतलं होतं. तिने जेव्हा त्या सगळ्या मोठ्या पेशंटना बघितलं तेव्हा ती घाबरून गेली होती. They came in the night and she came with her mother. They came in the night. Duty doctor informed me about what they found, and we decided what pain medication is to be given, and it was given to her. जेव्हा मी दुसऱ्या दिवशी सकाळी गेले तर मला पहिल्यांदा तिला भेटायचं होतं, नवीन पेशंट ऍडमिट झालेले म्हणून. मी जेव्हा गेले तिथे तेव्हा तिने घट्ट डोळे मिटून ठेवले. तिला अजिबात कोणाशीही बोलायचं नव्हतं, तिला तिकडे राहायचं नव्हतं, तिला काहीच आवडत नव्हतं तिथे. Because the whole environment was different. She was overwhelmed. There were so many people. She was in pain. Though pain medication had given her some relief, it wasn't complete because we just assessed her last night and we have given basic pain medication, right? So her mother was trying to tell her that doctor has come, open your eyes and tell her what is all happening. She said, I don't want to talk to anybody. Okay. Listening to this, I told her mother that I am going to be there in the center whole day till 4 o'clock. And before 4 o'clock, whenever she feels like, mother should be bringing her in a wheelchair to me, and we will meet her in my cabin. I told her this. I saw other patients with my team, आणि आम्ही त्या वॉर्डच्या बाहेर पडलो. दुसऱ्या वॉर्डमध्ये गेलो, पेशंट बघत होते. तोपर्यंत त्या पहिल्या वॉर्डच्या नर्सनी मला येऊन सांगितलं की ती उठली आहे आणि ती म्हणतीये की फक्त त्या मॅडमनाच भेटणार आहे मी. मला बाकी कोणी नकोय. त्या ज्या मॅडम येऊन गेल्या त्यांच्याशीच भेटायचंय. So, if you can understand from a point where she didn't want to meet anybody,
Right.
she kind of chose to meet somebody in private. It wasn't about me or anything. That we have to understand patient where they are, not where we are. The whole situation was so overwhelming that she was not comfortable talking in front of everybody. So eventually, then she came with her mother to my cabin with a nurse and a junior doctor. And then she started talking. She was comfortable. I tried to give her a chocolate and, try to make her comfortable. And then we had a wonderful talk. I asked all the possible history in the language what she understood.
Mhm.
And I could understand her main issue. See, त्यांच्या आईनी त्यांना घेऊन आले होते तेव्हा पेन हा सगळ्यात मोठा प्रॉब्लेम होता. त्यांना औषधं मिळाली होती, जवळच्या डॉक्टरांनी पण काहीतरी दिलं होतं, कोणीतरी इंजेक्शन येऊन दिलं होतं, पण पेन कमी होत नाही हा आईचा मेन प्रॉब्लेम होता किंवा तिचाही होता. तिच्याशी मी जेव्हा बोलले तेव्हा ऑन द कॉन्ट्ररी टू धिस शी सेड, माय बेसिक इश्यू इज आय वॉन्ट टू गो टू स्कूल. I want to meet all my friends on a daily basis. I want to sit in the classroom. I want to meet my teacher because kind of that was her world. Sitting at home, seeing parents worried all the time, pain not relieving was not something what she was expecting. And in that, she was brought into a place where everybody was having some or the other problem.
Right.
So that was totally different environment where she was not comfortable. She was irritable. We talked about various issues about her school, her likes, dislikes, and then that meeting ended by saying that as soon as she is pain free for 24 hours, I am going to relieve her from that place. Somehow we could tell her that we are genuinely interested in her pain relief. And once the dose is set, she is free to go. I said, then our team will come to your place. We will see if you are comfortable. And then if you are comfortable at home with medicines, we will take you to school.
Okay.
So we kind of had a plan aligning with what she wanted. ते केल्यामुळे काय झालं, इमिजिएटली तिला असं वाटलं की ह्यांना आपल्याला काय पाहिजे ते कळते आणि त्याच्यासाठीच ते प्रयत्न करतात. सो ती आमच्याकडे 8-9 दिवस होती आणि शी गॉट लिटल बेटर पेन वाईज. आजार तर वाढत होता पण आणि मग ती घरी गेली. ती घरी गेल्यावर आमची होम केअर टीमचे डॉक्टर एक 7-8 दिवसांनी घरी गेले आणि तिथून मला त्या डॉक्टरांचा फोन आला की मॅडम आम्ही हिच्या घरी आहोत आणि ती आम्हाला तपासूच देत नाही. कारण ती म्हणाली की मला मॅडमनी सांगितलं होतं त्या घरी येणार आहेत, बाकी कोणीच मला तपासायचं नाही. Again, there is some learning for us that time that once you promise the patient, you try and fulfill it. And though we had fulfilled it by my team going there, I didn't go because I was busy somewhere. So finally, I spoke to her. I told her that I will be coming after finishing today's work, but she should let the doctor check her and give medicines. I will come in the evening, however late it is. So finally, after finishing my work, I went to her place and she was okay. She was pain free that time. And you can see here, she was happy as well.
Yes.
And in my mind, for a second, I thought that, her parents would have told me की मॅडम आज नाही आलं तरी चालेल, आता तशी बरी आहे ती. But for her, it was again the promise which was fulfilled. She actually said, मला बघायचं होतं तुम्ही येणार की नाही.
Oh.
आणि आता मला माहितीये की तुम्हाला माझं घर पण माहितीये. So whenever I need, you would come. That was dangerous thing for me as she was becoming dependent on me. But on the other hand, it is that trust we were building from our services, which gave comfort to her that anytime anything happens, we are there.
Absolutely.
Yeah. So I think आपण जे सक्सेसचे गोष्टी बघत होतो, so this picture stays with me forever. And हे स्माइलिंग फेस आणि आई बाबांना सुद्धा जे बरं वाटलं होतं, that is something what palliative care can contribute. Yeah.
Yes. Such a happy picture. I'm sure it will remain with her also forever. So while narrating this story, you also spoke about her mother and the whole family.
Yeah.
So from the family angle, like when someone in the family is seriously ill, everyone is affected in different ways.
Yeah.
So what are some of the most common struggles you see among caregivers and family members? And how does palliative care support them?
Yes. So and I have just put this picture saying that palliative care, we call it as it is very low take. ह्याच्यात खूप rocket science नाहीये. It can be given at home, it can be given in the hospital, or it can be given in a standalone palliative care center or a hospice. याच्यात बेसिक गोष्टी ज्या असतात त्या म्हणजे कुठल्याही पेशंटला व्यक्ती म्हणून समजून घेणं, त्यांच्या लाईक्स डिसलाईक्स, मागच्या वेळी तेव्हा जेव्हा त्यांना गंभीर त्रास झाले किंवा डिफिकल्ट सिच्युएशन आल्या तेव्हा त्यांनी कसं त्याच्यावर मात केलीये हे समजून घेणं, त्यांचं सपोर्ट सिस्टीम काय आहे समजून घेणं, त्यांची सायकी समजून घेणं. काही वेळा इन ओल्डर पीपल वेदर दे आर स्पिरिच्युअल, व्हॉट इज देअर स्पिरिच्युअलिटी, आणि इथे मला रिलिजन आणि स्पिरिच्युअलिटी ह्याच्या डिटेल्समध्ये नाही जायचं, पण ट्राईंग टू हेल्प नो देम मोर आणि गिव्ह धिस सर्व्हिस द वे दे वॉन्ट इज व्हॉट पॅलिएटिव्ह केअर इज. वी कॅन डू इट एनिव्हेअर रिअली. प्रत्येकाच्या काही प्लसेस मायनसेस आहेत, बट टेक्निकली इट कॅन बी गिव्हन. So coming to your question about family members and how they take it, it naturally depends on the disease, age of the patient, stage of their illness, and the overall situation. For example, we saw the case where the girl was very young and parents were totally involved. They had kept their life on hold and they were involved in patient care. For somebody like this, they are actually living her illness, knowing very well that she is not going to be there forever for them, with them. This girl had a younger brother, so it was affecting his development also. So as a mother, she was worried about this girl, but she was worried about the other child also. Father was working, he had to think about leaving his job in between because it was prolonged illness where even mother needed his support. So it is very individualized, it is very very personalized in the sense some cancers there are wounds, like young लोक असतात जे बरेचदा गुटखा वगैरे खाऊन त्यांचं अर्ध फेस गेलेलं असतं आणि जखम असते. सो लुक्स वाईज ऑल्सो दे डोंट वॉन्ट टू फेस द कम्युनिटी. त्यांना सगळ्यांच्यात जायचं नसतं, ते लोनली असतात. कधी कधी त्यांना खाण्याचा प्रॉब्लेम येतो, त्यामुळे ते बारीक झालेले असतात. सो एव्हरीबडी हू सीज देम विल आस्क व्हॉट्स रॉंग विथ यू, आर यू नॉट टेकिंग ट्रीटमेंट. सो इट अफेक्ट्स फॅमिलीज इन अ वे लाईक आर वी डुईंग राईट ट्रीटमेंट, पैसे कमी जास्त पडतात, अजून बेटर सेंटरला न्यायला पाहिजे का, बॉम्बेला जायला पाहिजे का, टाटाला जायला पाहिजे का. सो आणि काही वेळा जर ब्रेडविनरच पेशंट असेल तर घरातलं फायनान्शियल डायनॅमिक्स पण सगळं बदलतं. रोल रिव्हर्सल होतात आणि ते इतके फ्रॅक्शन ऑफ अ सेकंड मध्ये होतात की कुणालाच ते नवीन रोल ची ड्युटी करताना दे आर नॉट परफेक्ट. सो त्यांच्यामधलं जे डायनॅमिक्स आहे ते बदलून जातं आणि समटाइम्स इट लीड्स टू केऑस. आय मीन समटाइम्स पीपल टेक इट ॲज इट कम्स बट समटाइम्स इट्स व्हेरी व्हेरी डिफिकल्ट. अशा वेळी आपल्या टीमनी त्यांना हँड होल्डिंग करणं, इवन नातेवाईकांना इंडिव्हिज्युअल म्हणून समजून घेणं. आता ट्रीटिंग टीम म्हणून आम्ही समजू शकतो की घरी गेल्यावर नातेवाईकांना ड्रेसिंग करायला हरकत नाही. हे म्हणणं जितकं सोपं आहे तितकं ज्याला कुणाला ब्लडची किंवा त्या जखमेची भीती वाटते त्यांच्यासाठी ते करणं खूप अवघड आहे. त्यांना दिवसा रात्री झोप लागत नाही, ते दुसरं काही सुचत नाही, जेवण जात नाही. पण त्यांनाही सपोर्ट करणं फार महत्वाचं आहे. काही वेळा इट डिपेंड्स ऑन इंटरडिपेंडन्सी ऑफ पेशंट अँड फॅमिली. म्हणजे बरेचदा डिमेन्शिया किंवा अल्झायमरच्या पेशंटमध्ये आम्ही बघतो की त्यांची मुलं बाहेरगावी असतात आणि पेशंटचे केअर गिव्हर्स हे त्यांच्याच वयाचे असतात. त्यांना पण काही मेडिकल प्रॉब्लेम्स असतात, आपले आपले इश्यूज असतात. पण पेशंटच्या साठी त्यांना सगळं करावं लागतं, त्यांचं लाईफ होल्डवर ठेवायला लागतं, सोशलायझिंग बंद होऊन जातं. त्यात त्यांच्या मेडिकल इलनेसेसमुळे लिमिटेशन्स असतात आणि देर इज नो सपोर्ट सिस्टम. I think that is where places like Aaji Care are really help to them. Sorry. So when you know their needs, then we are able to help them precisely.
Absolutely. So one question a little out of line. So
Yeah.
तुम्ही बोललात की पॅलिएटिव्ह केअर मधले स्पेशल डॉक्टर्स असतात, पण पॅलिएटिव्ह केअर मधली टीम काय काय असते, म्हणजे हू ऑल आर इन्व्हॉल्ड इन पॅलिएटिव्ह केअर ट्रीटमेंट?
या सो मी जसं आता शेअर केलंय तर डॉक्टर्स तर ट्रेनिंग घेतात, पण नर्सेसना सुद्धा ट्रेनिंग असतं. मेडिकल सोशल वर्कर्स आणि काउन्सिलर्स यांनाही स्पेशल ट्रेनिंग देता येऊ शकतं.
ओके.
काही वेळा सिनियर व्हॉलेंटियर्स ज्यांनी लाईफ खूप बघितलंय, वेगवेगळ्या अँगलनी बघितलंय, काही लोकांना अशा आजाराच्या लोकांची काळजी घ्यायचं भाग्य मिळालंय म्हणेन मी. त्यांच्याबरोबर ही जर्नी त्यांनी शेअर केली आहे. त्यांच्या एक्सपिरियन्सेसनी त्यांचे काही ठराविक ठोकताळे असतात. त्यांना काही ट्रेनिंग देऊन आपण सक्षम करू शकतो. आणि हे ट्रेन्ड रिलेटिव्स ॲट होम सेटिंग आर आवर आईज अँड इयर्स रिअली. They give us lot of actual inputs to look after these patients.
Okay, great. All right. Just one last question. So all this that you explained, I'm sure is very emotionally demanding on your side also. Not just yours, but the whole palliative care team that you just explained about. And
Yeah.
you have worked so extensively with patients and families over so many years. So how has it impacted your life as a person and a professional?
Okay. Good question, actually. See, when I shifted from anesthesiologist to palliative care person, it was total shift of thinking. Like as an anesthetist who has worked in ICU setting, we worked for saving life at any cost. And this was total shift when I decided to work in palliative care and relieve somebody's pain and suffering. It is like end of the day, whatever you do, however you do, somewhere you as a professional also, you have to accept that we are all going to be dying one day.
Yes.
It's total shift in me to accept that thing before I started working. The thing is, I think I was very young when I made this decision. Uh, Not really had life experiences in that level. And I used to struggle initially. But I think the moment I realized that I have to accept somebody's life, or for that matter, my life, as it comes, and
Mm.
not fight to, of course, we should try to make it better. That is the essence of palliative care, but not fight to change it completely, which is probably not going to happen. So
Right.
that acceptance slowly taught me how I need to make changes in my behavior. I'm not sure I have learned it completely yet, but it's a constant reminder that we don't know tomorrow what is going to happen, then at least make today better. It's a frequent reminder at every level, may it be home, may it be the team, professional team where you are working, or with other professionals. Our natural response is to react.
Right.
If somebody is not behaving properly with me, I will also give them whatever answer. But then to step back, pause, and think why that person might have behaved like that. He may have some point in behaving like that. And if it is okay, if it is that way, I did my bit and that's the end of it. I think I have learned to be like that more and more. And
Mhm.
I think over the years, seeing patients, seeing families, seeing their interpersonal relationships, and what comes out of that. Sometimes families, they have good closure after this event, but sometimes they suffer.
Yes.
I think when I come back home every day, every time, seeing such challenging patients, difficult, I just come back with lot of gratitude for having good family who supports me, who made me understand that okay, if it is your wish to work in this field, we support you.
Yes.
I really feel grateful for the team members. Like, I got into palliative care. Some people are working in palliative care as a job, but
Hmm.
then when they are with me, they are trying to do better and better and to make a better team. So I really feel very grateful for the each team member who is contributing their bit for betterment of somebody else. Money and all that is different issue, but wanting to do something for fellow human being is the basis. And I think I feel really grateful to have that human experience every now and then. It's a lot of gratitude, really.
That's such a beautiful thought. Absolutely.
Thank you.
All right. You know, just asking, opening the forum for our participants also to see if they have any questions. I'm sure a lot of them have. Somebody
So
has,
should I just stop this
yes, and
share?
we can go ahead with questions. So, Sonali has asked this question. Does palliative care can be
It
uh,
is stopped, right?
it is. The
Yeah.
presentation is not there.
Yeah.
She wants to know is if palliative care can be applied for disabilities like severe cerebral palsy and muscular dystrophy and global developmental delays as well.
Okay. So, very honestly, technically, yes. To what extent pediatric palliative care specialist? I'm not a pediatric palliative care specialist, but going by the rule book or the principles of palliative care, even these children need some help to make their quality of life better. And for doing that, one has to work with them to know how much better we can make them while they are going through this. Plus, working with their parents, I'm sure definitely we can definitely use some principles of palliative care.
All right. Okay, so we have opened this forum for questions. First of all, I would like to understand if you understood palliative care. Was the information helpful to all of you? . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 . . 。 . 。 . 。 . . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 . . 。 . . . . 。 .
。
Okay.
I think only one person understood, I guess.
No, I think all of them are showing thumbs up.
No, it is a difficult concept to understand.
Absolutely. Okay. Do you have any questions for doctor? Somebody is asking, can spirituality also be integrated as part of the palliative team? And
Yeah, the answer is yes. Uh, the Western teams, I would say, they have a chaplain regularly a part of these teams. Working in India, it is difficult. We deal with different thought process people, and we don't really have a guru or a chaplain as a part of team. But what we certainly do, there are scales in which you can do some spiritual assessment. We do that, and those people, according to their faith, I'm not saying religion, but according to their faith, we try and fit them or get them guidance when needed, but not as routine as it happens in Western world.
Mhm. Okay. And she also wants to know whether you have worked with dementia patients and how does palliative care work, function in dementia?
Okay. I have worked for last few years, not 24, 25 years, but last few years. And the thing is, it's very difficult to explain, but palliative care, again, in their condition where they don't know who they are, where they don't know who others are, I think going and meeting them consistently every day, sitting with them, making them understand one or two concept every day repeatedly, getting them do some activities which are fixed kind of a thing, you know doing it gives them that happiness that they are able to do something. It may not be like other patients who understand cognitively much better. It is different, but definitely we can add on to make their quality of life better.
So would that
Definitely.
also be the primary goal of palliative care for a person having advanced dementia? That's actually a question from one of the persons.
Yeah, so one of the primary goals, yes, but the patients who come to palliative care as such, of dementia, they do have, they are, what I have seen majorly when they come to me, it's pretty advanced. They are not able to move from their bed. They do have contractures because they have not used their hands and legs for long long time, and cognition of course is a issue. So they do have medical issues, they do. And when they're trying to feed them, there is constant coughing, and food goes into their windpipe, and issues related to that. So then they do have bed sores sometimes at that stage. So they do need medical management, nursing care, and uh, in addition, some counselors or medical social workers dealing with them on a regular basis. Of course, physiotherapy included.
Okay, okay, understood. And Bhagyashri wants to ask if homeopathy treatment being tried for emotional well-being of this treatment.
So I have not studied homeopathy that well, but I know at the same time that many patients of different diseases, they do try and venture allopathy, Ayurveda, and homeopathy along with each other. And for some patients, it helps. So I think I am not the authority to say that it definitely helps or it doesn't help, but I'm sure there must be some work to it, and we need to explore it with homeopathy experts, really.
Okay, okay, great. Okay, do we have more questions? All right. So, as we come to the end of today's conversation, I would like to express our heartfelt gratitude to you, Doctor.
Thank you.
Not only from Aaji Care, not on behalf of Aaji Care, but thank you from all the people who have attended this session today. Thank you for reminding us that palliative care is not about giving up only, it's about giving comfort, dignity, and hope as well.
Yes.
So thank you so much again from the bottom of our hearts. And we look forward to having much more conversation to you with you in the future.
Sure.
Thank you
Thanks.
so much, ma'am. Thank you.
Thank you.
And thank you to all the attendees as well. Thank you.
Thanks.
See you next month. Thank you. Bye-bye.